Morning, everyone. This is Neil Davis. It's 7:30, so we're going to get started on our weekly COVID WebEx. A couple announcements just to begin. The Utah chapter of the AAP sent out an email to many of us that are involved with the AAP, inviting us to a chapter chat at 8 o'clock. That's a Zoom meeting where folks can join and ask questions of members of the board and collaborate together. So for those who are interested, right after this meeting at 8 o'clock, there is a Utah AAP chapter chat. So look for that email from the Utah AAP if you're interested. Let's go ahead and get started with our presentation. Just as a reminder, everyone has been muted, and we would ask that your questions be submitted via the chat function down at the bottom of your screen. I want to introduce our guest. We have Andy Pavia, who many of you know, and we're very fortunate to have you here today, Andy, so thank you. Andy is the George and Esther Gross Presidential Professor and Chief of the Division of Pediatric Infectious Disease at University of Utah Primary Children's. He did training in medical school at Brown University and then at Dartmouth, where he was a chief resident. He also did a preventive medicine fellowship or training at the CDC, where he worked, among other things, on HIV, and then did pediatric and adult ID fellowship at the University of Utah. He is internationally known for his work on viruses and outbreaks, and just a wonderful colleague. So, Andy, welcome, and thank you for being with us. You can go ahead and share your screen. We will keep track of the questions that come in, and then I will filter those to you when we get to the Q&A part.
All right, let's see if I can master this. Thank you, Neil, and thanks everybody for coming this morning. Thanks for having me. Let's see. A little bit of trouble. There we go. Let's see, is it sharing my screen yet, my slides?
I don't see them yet.
Okay.
There's a little circle icon at the bottom of your screen with the little up arrow in it.
Yeah, no, I've clicked on it. We just doesn't seem to have taken it yet.
There we go. It seems to be coming. Okay, go ahead.
Great, thanks everyone. So I'm going to go run through a quick review of where we are now in the epidemiology, and then I'll finish up with kind of some of the new things we've learned about children and end up a little bit with some open questions about managing infants born to women with COVID-19, because we're seeing more and more of that. So a good place to start is with the 1918 pandemic. These are police officers in the streets of Seattle, and it's eerily reminiscent of where we are today. I've shown this timeline in a number of settings. This is from an official publication from the Chinese CDC, and I would ignore some of the small print that shows different time events, because some of those are subject to some controversy. But what I want you to notice is that the first known case was in November of 2019, November 7th to be precise. And if you allow for undetected cases and the 5 to 7 day incubation period, then we know two things. One is we know that the outbreak probably began in November. And the other is that if you look at the distribution of cases associated with the much maligned seafood market in Wuhan, you see that actually most of the very early cases were not associated with that. So there's a lot that we don't know about the origins of this virus, but the commonly told story about the Wuhan seafood market is probably incorrect. I think you've all heard the story of Dr. Li, who tried to bring it to attention. And the only reason I show this again is because I think the story that we're beginning to appreciate, even as we get into May of 2020, is a story of warnings unheeded. And I want you to keep that in mind as we go forward. I think everyone knows that Dr. Li died of coronavirus after initially being arrested and then returned to work in the overcrowded wards. The scientific advances have been pretty dramatic. You can see the coronavirus in an electron micrograph here, and that was from mid-January. The sequences were published in the first week of January. Given the pace of scientific knowledge and the pace of scientific discovery, you might have thought that we would get this under control rather quickly. And I think everyone knows that that's not really the case. Most people probably start their morning by looking at the Hopkins website to look at the daily toll, unless you become so fatigued by the numbers that you don't do it anymore. But we're now at something over 3 million cases worldwide, of which 1 million are in the United States. We're closing in on 250,000 known deaths. But if you saw the CDC COVID website this week, you realize that the increased mortality is something in the range of twice the mortality that's associated with confirmed cases of coronavirus. If you look at overall deaths, they greatly outpace the ones that test positive. Is this because people aren't getting medical care? Is it because people are dying at home? Is it untested deaths? We really don't know. The waves of the outbreak throughout the world have been pretty interesting. In orange over here, I don't know if you can see my pointer, you see the outbreak in China. You then see Europe becoming really the hot spot, then the US. And what doesn't show up here very well because of poor surveillance is the Middle East and Africa. And I would advise you, in the broad sense, to keep your eye on the poor areas of the world, because I think later this year, that may be the big story. But let's turn back to the United States. Sometimes the maps coming from our newspapers are actually better than the ones that CDC puts out, even the ones for internal briefing. And I like this view of the outbreak that is from a mapping function on the New York Times, and because it's by county. And what it shows you is that there is disease in almost 100% of US counties. You are all aware of the hotspots: Southern Florida, New York metro area, Boston, Louisiana, Southern California. But look at the degree to which the disease is really everywhere. And there's a lot of denial about where it is. We'll hone in on Utah in just a second. If you look at the overall US epidemic curve in the lower right, you see that there is a flattening in new cases and the beginning to be a flattening in deaths. But what I caution you, and I caution everyone, is that looking at the curve for a single country of 330 million is really misleading. Even in Utah, we're looking at micro outbreaks where what's going on in one county doesn't reflect what's going on statewide. So let's look at what's going on in Utah. In the upper panel are the case counts, so the epidemic curve of PCR diagnosed cases for the state as of yesterday. And you may be much better at curve fitting than I am, but it's actually pretty hard to discern a single unified epidemic curve here. We have a period of rapid rise, we have a period of decline, and then we've had a period of rise again, and now it's not clear exactly where things are going. And I think a lot of that is attributable to the fact that when it dies down in one county, it flares up in another. In the lower right, you see the number of tests done. Utah is in the top quartile of states for the number of tests done per capita. So we're doing reasonably well grossly. What we've begun to realize is that we're not necessarily testing where the disease is and where the risk is. For instance, per capita testing on the west side of Salt Lake City is much lower than per capita testing on the east side. But this is a map of the incidence of cases by population in Utah, small areas, smaller than counties, in the last 7 days. And you can see this very hot area here on the west side of the Salt Lake Valley, where I just told you we're not testing enough. And then look at this, Utah County, Provo, South Utah County, and Payson are among the most active places in the state, as is San Juan County. And this is not what we saw a couple of weeks ago, where most of the activity was in Salt Lake, Davis, and particularly Summit and Wasatch counties, which have now quieted down quite a bit. So that's kind of the way things are evolving rapidly in Utah. Stick around a week and it's going to be different. No good epidemiologist can give a talk about a viral disease without using an iceberg analogy. So I want us to think for a minute about the iceberg of COVID-19 disease. And we've known the upper part, about what's above the waterline, for quite some time. We know that um, in the US, about 5% of cases end up in the ICU, 14 to 15% overall are hospitalized, but 80% of all ages, all comers, are mild to moderate disease. And this is pretty similar to the data that came out of China months before that. What we still are struggling with, but I expect us to have much more data in the near future, is what's under the waterline. Undiagnosed cases represent a big problem. Who didn't get tested, either because they had poor access to care or they had mild disease, and then who was asymptomatic. Our initial estimates of the proportion of asymptomatic cases was that about 25% of all infections were asymptomatic. As we're beginning to get serosurveys, we're learning that that was a massive underestimate. We don't really have any reliable population-based serosurveys yet. The New York study, which was a convenience study, estimated that up to the multiplier might be as high as 10 to 20 of undiagnosed cases to diagnosed cases, but I would take that with a grain of salt because of the sampling method. Here in Utah, with funding from the state and collaboration from a number of parts of the University of Utah and the Utah State Health Department, we are launching a systematic population-based serosurvey that's going to look at Summit County, Utah County, Salt Lake County, and Davis County. And that should really tell us a lot about what's under the waterline in the iceberg. All right, let's focus on children a little bit. You've probably seen the age distribution graphs from national data or Chinese data. Here are the most recent data from Utah, and you can see that if you look at case counts, the highest number of cases by far is among people 25 to 44, and the number of cases in kids under 15 is pretty modest at about 177. If you look at incidence per capita, you actually see something interesting, and that is that the incidence in infants of diagnosed cases is about twice what it is in kids 1 to 14 years. I don't know why that is. My leading hypothesis is that we work up febrile infants under 90 days, which increases our awareness, but we really don't have a good answer for that. And again, you see the really important role of very young adults and younger adults in the overall infection incidence. And of course, these are the people who either are being infected by our kids or are infecting our kids. We've known since really January that the disease does not hit kids particularly hard. These are national data from the MMWR from a couple of weeks ago, looking in the left at overall hospitalizations, then ICU admissions in the somewhat darker blue, and deaths. And nationally at that time, there were no deaths and almost no ICU admissions in kids in a data set that was about, at that time, 190,000 cases. And you can see that when you get up into the 20 to 44-year-old group, the hospitalization to ICU admission ratio is quite a bit lower than it is, say, in those over 65, where up to a quarter of those admitted to hospital end up in ICU. And you can see that the death rate just increases steadily. So kids seem to be spared severe disease. That's not to say it hasn't happened. There are kids who've been admitted to ICU. The number of deaths is shockingly small so far. The one death that got the most attention was a child in Chicago who we came to learn was an extreme preemie, so we don't know how generalizable that is. What about symptoms? How different does the disease look in children? Again, this is from a CDC study, and blue are the percentage of symptoms in children, the orange are adults. And you can see for most of the symptoms, they're somewhat less common in children. And that's in part because a greater number of children are just totally asymptomatic than adults. What is the actual number of asymptomatic infections in kids? We won't know until the household studies and the serosurveys are really done. What's kind of striking to me is that unlike flu, where diarrhea and abdominal pain are more common in children than in adults, the reverse appears to be true in kids, but it's still some 10% of kids who present with GI symptoms. CT findings of COVID-19 have been particularly interesting because of this very sort of stereotypic ground glass pattern that you see, with the infiltrates being very peripheral. On the bottom from this paper are 3 adults with fairly typical findings, though this person has a little bit of consolidation here. And above you see kids. And what this study concluded was that the findings are very similar in character, but in general they were more sparse among children. So far we've talked about kids doing better than adults, but there's an intriguing new question that's been raised. On Monday, the UK Ministry of Health issued a warning that they had seen a number of cases of a shock-like illness. And it was poorly described. There were features of toxic shock syndrome with sudden vascular collapse and multi-organ dysfunction, and there were signs of arterial inflammation, including some who had coronary inflammation. The question was raised, was this Kawasaki's disease? Was this Kawasaki's like disease? And that remains a very open question. There are 3 similar cases that have been discussed in the US, but as we're starting to discuss it on message boards, there are more cases. And it remains unclear to me as of today what's really going on. Are we seeing Kawasaki's coexisting with incidental diagnosis of COVID-19? Are we seeing a unique syndrome triggered by coronavirus? Or are we seeing classic Kawasaki's triggered by coronavirus? Stay tuned. I really can't answer a lot of those questions right now. I don't think anyone can. I won't spend a lot of time on lab abnormalities, but if you are looking at a kid waiting for the studies to come back who has moderate lung disease, you should be looking to see if they have lymphopenia, which is quite common and quite characteristic. C-reactive protein can be elevated, but procalcitonin is typically normal. And we use it on admitted kids to look for the development of secondary bacterial infections, which have been quite rare compared to similar numbers of influenza. So in the interest of keeping this short, I'm going to move on to where we are now with the idea of control and reopening. So control is possible, and probably the country that has best demonstrated this is South Korea. Now, I think the circumstances in South Korea were very different. They jumped very early on their explosive point source introduction in the church in a single province. They ramped up their testing to an enormous degree. They enforced isolation and quarantine. That is, if you tested positive, you were actually tracked to make sure that you practiced isolation. And if you were asked to quarantine, you were given an opportunity to quarantine in hotel rooms, but it was also fairly strictly enforced. But what you can see is that after control of the outbreak, they continue to have a steady number of cases predominantly associated with introductions from outside. So no matter how well you control the initial outbreak, continued vigilance seems to be important. So what are we going to do in the US? There are a number of strategies that have been put forward. I don't actually think much of the president's plan, so let me talk about one that I think was very well thought out and data-driven. And this is the one that came out of a group coordinated through the Hopkins Center for Biosecurity. And it's just representative of a number of thoughtful plans. Scott Gottlieb and Mark McQuillan, former FDA chief and former CMS chief, respectively, were among the co-authors. The others were epidemiologists. And there's the URL, so you can look at this. But the strategy is similar overall to what other people are approaching. First is slow the spread. And for this, you need really good data, and you need to actually demonstrate that things are on the decline. Then reopening, done state by state, when each state hits appropriate levels of decreasing incidence and meets these other criteria. They have to have improved health system capacity with enough excess beds to respond to a new surge. They have to have a good PPE supply. They need to be able to launch large-scale contract tracing and isolation, and they need to be politically, socially, and psychologically willing to return to phase 1 if it's needed. Phase 3 would follow thereafter, and that would be to establish protection, lift all restrictions. This would be done with vaccine scale up and mass vaccination. And then what I think is particularly important is phase 4, try and capture the lessons we learned and return to readiness. So in Utah, when the plans to reopen began, the R0, or RT, the reproductive number, had fallen below 1, and it looked like a pretty good time. From the numbers I showed you, we're not there anymore. We now have an R0 of about 1.3. So I'm personally nervous about whether we're moving too quickly, but we are moving, and this is the plan that we're following. This is the version put forward by the Levitt Group, which is a good deal more detailed than what the governor actually put out. But it's a thoughtful, multi-phase approach that starts with 4 phases, not the 3 of the Gottlieb plan. We're currently in red. We are going to be moving towards orange. It has sections for all different industries. This is the healthcare industry, which you can't see. And in the interest of time, I'm just going to look at one little example, and that is surgeries and procedures. And we are, as we move to orange, the key steps are going to be, let's see, we have to make sure that I can actually, it's supposed to, all right, here we go. This is the version. So in surgery, I've got this set up the wrong way. Okay, so begin with the bottom. Outpatient elective surgeries for low-risk patients can proceed when reliable COVID is available and critical resources are sufficient. Acuity drives prioritization. That is, particularly with kids, we do surgery on those who can't afford to wait, where the risk of delay risks poor outcome. And then for clinics, it talks about maintaining as many visits as telehealth as is appropriate, or deferring in-person care if that can safely be done. Use face masks and eye protection for all non-patient facing staff, and face masks and eye protection for all patient facing staff. And we can talk about that and sort of how to operationalize that in individual practices. And then, of course, you mask patients. And as we think about how well that's going to work, it helps to look abroad and look at what's happened in a number of different states. I think the data from China should be viewed with some grain or bucket of salt, given the desire to improve their political image overseas. But China is not reporting a large resurgence, so that's really interesting. I showed you South Korea earlier that's had continued success, but Japan is an object warning in that they had fairly good control here, and then they've had a rebound. And the Singapore data are relatively incomplete. Singapore dropped their numbers dramatically, but is now seeing a secondary resurgence. And so we really don't know what we're getting ourselves into with reopening, and we're going to have to be really on our toes and adjusting as we go. Been one of the hard things throughout this epidemic is to kind of have a new approach every week, but I think that is not going to get much better. Now, I don't have slides for the last thing I want to tell you about. Didn't have time to make them, and I'm not sure I have permission to put it in slides, but we thought this was particularly important, and Neil was on a call yesterday where we talked about this. Our colleagues in New York City started testing all pregnant women before we did, and they found a large, not all pregnant women, all women who were going into labor, entering labor and delivery. And throughout the city, they found a surprising number of infected women, many of whom were asymptomatic. And we've gotten some details from our colleagues at Columbia, at the 2 major Columbia hospital system hospitals. They, in the first 6 weeks or so that they were doing this, found 80 infected women in labor, most of whom, I believe it was 54 out of 80, were asymptomatic, which was quite surprising. Although, how do you detect symptoms when you're active labor? So take that with a little bit of a grain of salt as well. Because they didn't have room to separate infants from their mothers, For all of the mothers who were relatively well, the babies were allowed to room in with the mothers. They slept 6 feet from the moms. Virtually all of the mothers initiated breastfeeding with masks, hand hygiene, and breast hygiene. We're not sure exactly what that constituted. And to date, in the follow-up that they've had on these kids, there was not a single case of vertical transmission from mother to child in breastfeeding. This goes against what AAP has put out, preferring separation. This goes against CDC's initial recommendation that sort of said separation is probably preferred, but we should pursue joint decision making. And as we looked at these data and thought about what it was telling us about the potential safety of breastfeeding against the pretty mild disease in kids, we really wondered whether safe breastfeeding and safe rooming in, that is, sleeping at a distance, mom masking, mom doing obsessive hand hygiene, may not be the first choice, with separation reserved for sicker women, those who are not breastfeeding, and those who just don't want to take a slight chance on infection. So I want to stop there because I'm sure there are a lot of things that people want to talk about that I didn't cover.
So Andy, thank you. Can you hear me okay still?
Yes.
Okay. We've had a couple questions come in. Let me start with one from Mark Templeman. Since children are less affected, how do we decide when to reopen schools? Should we start with K through 6?
This is one of the really hot topics in public health. If we knew how much of a role kids had in transmission, then logically, one of the first things to reopen would be schools. If it's like flu, where they really drive the epidemic, there's a real danger in reopening schools early. But if, as we suspect, kids are no more likely to transmit than young adults, then opening schools has a lot of economic and as well as direct benefits for kids. What age group should you start with? Probably, K through 6 is an age group in which you can do something to improve hygiene, which is as opposed to pre-K or daycare, and where mixing, something you can control, and you also don't have the social relations and the kissing and the sharing of drinks and cigarettes and that sort of thing. So it's a reasonable hypothesis to test. But to my surprise, and to the surprise of a number of other epidemiologists, school reopening for the spring never quite made it on the table. Business reopening was given priority. I think that we probably could have started with cautious school reopening, but for the political decision makers, that may not have been enough economic stimulus.
Thank you, Andy. That's great. We have a question from Tony Wallen. Does it make sense to see patients outside when available in an outpatient environment?
It's a really good question. Right now, we think that, with 4 months of detailed experience, that for patients who are not undergoing an aerosol generating procedure, if you have access to mask, good eye protection, gown, and gloves, you can safely take care of COVID patients. And so that would include, doing full exams, giving them their vaccines. We're worried about kids falling behind on their vaccination. The one area for which you want more protection is when you're obtaining an NP swab. CDC still recommends having airborne protection for that. And if you don't want to run the risk of contaminating a room, then doing that outside is appropriate. So what I would say, if I was running a clinic, which I never have, is that I would see the kids in a regular exam room, perhaps during sick visit hours. But I would try and do, if it was possible, do my swabs outside.
Thanks, Andy. That's great. A similar follow-up question to that is just comments in general about airborne transmission. Sort of what is COVID in terms of airborne transmission? What are the true AGPs here?
Somebody want to ask an easy question? So there's a great meme on one of our websites that is a little GIF of a hospital epidemiologist with his head exploding, and the and the caption is, "What's an AGP?" We know what are AGPs for sure. So intubation, suctioning through a tracheostomy or through an ET tube in an open system. Positive pressure ventilation, depending on the circuit, is aerosol generating. Dental procedures are aerosol generating. I'm probably leaving one or two. Bronchoscopy is known to be aerosol generating. We have good data on that. There are other things that have been added to the list based on logic, such as ENT surgery and other procedures on the upper airway, things that have been added out of anxiety, like EGDs, transesophageal transesophageal echoes, but there are no data for many of the things that have been added to the list. Intermountain has a list of what we have decided to call AGPs. The university has one you can look at. Yeah.
Thank you, Andy. That's great. We are at time. For those who we didn't get to your question, we will track those questions and try and get answers to you with some input from Andy. So Andy, we put together our best answers, run it by you real quick, and then post it on the website for folks to see the answers. So thank you, Andy, very much for the information. Very thoughtful and very helpful. And thank you, everyone, for the questions. Again, we will follow up on those. Next week, our topic is going to be about mental health, particularly in teens, as it relates to COVID. And how do we manage our populations where we feel like there could be a swelling of anxiety, depression, and other things. So again, thank you, Andy. Thank you, everyone. And we hope you have a wonderful day.